as Thom tells it, this episode is going to be good for you, and you will not put your foot in your mouth. Tonight we have Dr. Chris Yardan with us. How are you doing today, sir?
Very good.
Why don't you tell us a little about your training, what you've gone through to get to where you are today?
Absolutely. So I'm originally from Branford, Connecticut. I went to Notre Dame West Haven, Boston College for undergrad, and then I went to the Ohio College of Podiatric Medicine, which is out in Cleveland, Ohio. And then I did a 3-year residency in South Florida in reconstructive foot and ankle surgery. Since then, I've been building towards getting board certified, and I've recently become board certified in reconstructive foot and ankle surgery by the American Board of Foot and Ankle Surgeons.
And you're right here in town.
Yes, right here in Wallingford.
Exotic and salvage. What are you talking about there?
Common things are common, right? Plantar fasciitis is common, all right? Tendonitis, sports injuries, even trauma to a degree is common, okay? Then you start getting into the things that aren't, the 10% or less of patients that we typically see, all right? Limb salvage, diabetes, failed surgeries, failed fusions, failed treatment of fractures of the ankle and what have you. And, you know, you bring this with diabetes as a comorbidity, with vascular disease, okay? And all of a sudden, these people that were not getting a good result from the initial surgery or had repetitive surgeries really didn't have an option, and we were amputating them above or below the knee.
How long ago?
I would say within the last 5 to 7 years, we've had a big jump in some of the technology and some of the techniques that we're using now that have afforded us more options for these patients. You know, not to get too technical, but, you know, when we would have a real bad situation where somebody's ankle was destroyed for whatever reason, whether it be a failed fusion, a failed surgery, multiple fractures, whatever it may be, okay, we would use these big bone grafts, okay? And, you know, bone grafts to a degree can be good when they're your own, but when you're talking about large segments of area that aren't going to be able to be filled by your own bone, because where am I going to get a big chunk of bone from you, right? There's places we can get small chunks and we can use them, you know, tastefully, we'll say. All right, but then there are times where there's big defects and we simply didn't have anything before. Now we have a few new options, and really that's come along with the 3D printing capability that you're seeing more and more in society today. And an example of that is right here. What I designed with some engineers from a company that basically does 3D custom implant design for orthopedic procedures.
What part of the foot or leg would that go into?
It's a combination of a couple things. It initially started as what we would call a trabecular cage, which is really just this, okay? And it started with spine surgery. And they were using these for defects in the spine. What we were doing in the foot was we were doing replacements of full bones, really in this case the talus. The talus is a bone that connects the leg to the foot, okay? And a lot of times when that talus was gone, for whatever reason it may be, we didn't have any options. Okay, we would fuse your heel to your leg, and we would take the whole segment out. And now all of a sudden you had a limb that was like that much shorter. Okay, and that's if you weren't infected, okay, or if you went on to what we call a non-union, where the bones just simply do not become one. Our goal in a lot of surgeries, all right, is to fuse the bones so that they become solid. And when that happens, it usually eliminates the pain. Okay. In this case, what this allows me to do is it allows me to span that defect with this. And so no longer do we get a significant shortening of your limb, and you don't end up with these two odd-looking legs, okay? And a lot of times when there's bone infection, we have to remove so much bone that someone may say to you, listen, it's not salvageable. We can't save your leg. We've taken too much at this point. We could try to do all this stuff, but the literature would suggest that it fails. So in this case, this is part of the talar head. This was the talar body. This still articulates with the joint. This fills the defect that was created by the failed surgery. And then we put this nail straight up the middle like that and lock it. And so for this patient, we take a CT scan, we put it on the computer, I sit on the computer with the engineers, and we basically design this whole thing from scratch.
For that particular
patient, correct. And then we actually take whatever residual bone is left over that I actually have to remove to put this in, and I actually have to crumple it all up, and I have to sit there for about a half hour.
Really?
And push it all in here. Yes, this cage is supposed to have these gaps so that the bone will actually grow all the way across this And this just becomes a scaffold for it, and eventually your bone becomes from here to here. And the whole surgery works.
And it stays in forever.
Stays in forever. Yeah, this will never. Some implants we have to take out. I tell the patients, it doesn't bother you unless it bothers me. This one, this isn't going anywhere. All right, but usually this really fixes the problem for these people. I've had 2 patients so far that I've had far enough out, 9 months plus, okay, who are totally pain-free, walking around. One of them was 74 and diabetic, okay? The other one was 52, had multiple surgeries, and was basically told there was no way to save her leg. And I convinced her that I felt like I could with this. She gave me the shot. It worked out, and she's praising me, and she really credits me for saving that.
Wow.
And, I mean, that goes on. You talk about the social impact of this. I mean, foot and ankle surgery in general is such an impactful surgery for people. If I told you that, you couldn't walk on your leg for 3 months, all right, your entire lifestyle would be different. You could go have heart surgery, maybe you have some other major abdominal or general surgery, and that's going to affect your lifestyle. It's going to affect your diet, right? It's going to affect maybe what you can do to a degree. But if you can't walk, you can't go anywhere, you can't drive, okay? You can't even really go to the bathroom without assistance, at least not until you really get comfortable with it. You're basically now requiring assistance from the people that you love to help you the most. And so that's one thing that I'm very adamant about with patients is making sure they have a support group behind them so that we don't have to deal with things that maybe could have been avoided.
So would that relate to this?
To a degree, yes. I mean, somebody who would have this would be non-weight bearing for months. So, to that degree, it's who's your friends, who's your neighbors, do you have a daughter, do you have a son, can they come? We're very proactive with that, with the patients to make sure that.
So if they can handle it, you're going to be able to walk again. You're going to be whole again.
Oh, 100%. My goal is to have you 100% pain-free, ambulatory, and doing everything. Now, their ankle won't move with that because their ankle's been locked, okay? But their leg becomes a stable platform so that
Will
now
they
can
walk
go.
regular?
You would never know.
Oh, okay.
I mean, you might see a small hitch in their gait, and you might say, I wonder if they have a hip problem or a knee problem or something, because they may not be fully symmetrical, all right? But they'll be pain-free.
They don't have to get the 2 different size shoes and.
No, that's one of the advantages of this. I don't need to do that, send them to boost them to equalize their limbs. So, yeah, it's pretty cool stuff.
All right, appreciate it, Doc, for coming
Absolutely.
in and talking to me.
Pleasure.
Yes, sir.
Yeah.